All right, at your patient's very first prenatal visit, you have a few core clinical goals. You need to definitively confirm it's an intrauterine pregnancy, accurately date it, figure out if there are any high-risk conditions right off the bat, and draw those baseline labs. This initial visit really sets up the entire foundation for both maternal and fetal management, so having the exact sequence of next best steps memorized is absolutely crucial for Step 2 CK. So what are those routine baseline labs? You're going to want to cast a wide net here. Check their ABO blood type and Rh status, and grab a CBC with indices to look for baseline anemia. You also need to aggressively screen for infectious diseases. This means testing for HIV, syphilis using a BDRL or RPR, hepatitis B surface antigen, hepatitis C antibody, and checking their immunity status for both rubella and varicella. Wrap all that up with a baseline urine culture and a urine protein dipstick. Now, if you're dealing with a high-risk population, specifically patients under 25 or anyone with high-risk sexual activity, you have to make sure a chlamydia PCR test happens at that initial visit. Here is the classic test day logic you need to know. If that initial test is negative, but a repeat test in the third trimester comes back positive, you're looking at a newly acquired infection. So always remember to repeat that screening in the third trimester for these specific demographics. You'll also establish the routine visit schedule right away. Think of it as accelerating the closer we get to the finish line. You'll see the patient roughly every 4 weeks up until they hit 28 weeks. From 28 to 36 weeks, you bump that up to every 2 weeks. And then after 36 weeks, you're seeing them weekly until delivery. This schedule is designed specifically so you can keep a really close eye on their blood pressure to catch preeclampsia, track fetal growth, and monitor for any warning symptoms as they approach term. When it comes to dating the pregnancy, how do we get the most accurate estimated gestational age? It's actually a first trimester ultrasound measuring the crown rump length, ideally done between 7 and 14 weeks. The margin of error here is incredibly tight, just plus or minus 3 to 5 days. So while a patient's last menstrual period gives you a decent estimate, that first trimester crown rump measurement is your definitive answer. Whenever a next best step question, ask about dating. Let's talk maternal physiology for a second, specifically the thyroid. This is highly tested. Beta-HCG actually stimulates the TSH receptors on the thyroid gland. That drives up total T3 and T4, which then causes feedback suppression, dropping the TSH levels. Because of this physiological shift, if your patient has pre-existing hypothyroidism, you literally have to increase their levothyroxine dose by 30% the moment they get a positive pregnancy test. After that, you monitor them every 4 weeks using trimester-specific TSH ranges. Your patients will definitely ask about exercise. For the vast majority, you'll highly recommend moderate activity. Walking, swimming, cycling, prenatal yoga, and light strength training are all fantastic. They help with weight management, lower the risk of gestational diabetes, and even shorten postpartum recovery. But you have to strictly counsel them to avoid anything with a high fall risk, contact sports, hot yoga, and scuba diving. Moving into prenatal genetics, you have to strictly differentiate between screening tools and diagnostic tools. First trimester combined tests and second trimester quadruple screens, those only give you a risk estimate. If one of those screens comes back abnormal, you have to get a definitive karyotypic diagnosis. You do that with chorionic villus sampling, or CVS, between 10 and 13 weeks, or an amniocentesis if they are past 15 weeks. Just remember, those diagnostic procedures do carry real, distinct risks of membrane rupture and pregnancy loss. Cell-free fetal DNA is a massive topic right now. You can order this from 10 weeks onward for high-risk patients, like those over 35 or the history of fetal aneuploidy. It is incredibly sensitive and specific for the common trisomies, 21, 18, and 13. But here is the catch. It is still just a screening test. If a cell-free DNA result is abnormal, you can't stop there. You still have to confirm it with a diagnostic CVS or amniocentesis. You need to memorize the exact maternal serum marker trends for trisomy 21 in the second trimester. It's a classic exam question. For trisomy 21, beta-HCG and inhibin A go up. Everything else, PAPA, estriol, and AFP, goes down. Compare that to trisomy 18, where virtually all the markers are decreased. Recognizing that specific pattern of elevated beta-HCG and elevated inhibin A is extremely high yield.
Let's look at Rh alloimmunization pathophysiology. If an Rh-negative mother is carrying an Rh-positive fetus, there's a risk that fetal red blood cells will cross the placenta and mix with her blood. This usually happens during delivery or if there's some kind of trauma. Her immune system sees those Rh-positive cells as foreign invaders and creates anti-D IgG antibodies. In her current pregnancy, it's usually fine, but in a subsequent pregnancy, those IgG antibodies can cross the placenta, attack the new fetus's red blood cells, and cause hemolytic disease of the newborn.
So, what's the immediate next step for any Rh-negative patient? You check an indirect Coombs test to screen for those antibodies. If the screen is negative, great, she's unsensitized. You'll just repeat the screen at 28 weeks and give her a dose of Rogam. But if that antibody titer is positive, she is already sensitized. At that point, giving Rogam is totally ineffective, and your management shifts entirely to monitoring the fetus for signs of anemia. For those unsensitized Rh-negative patients, timing your anti-D immune globulin, or Rogam, is everything. You give it routinely between 28 and 32 weeks, and again within 72 hours of delivering an Rh-positive baby. But don't forget, you also have to give it after any sensitizing event where blood mixing might happen. This includes things like a spontaneous abortion, an ectopic pregnancy, procedures like a CVS or amnio, abdominal trauma, or any second or third trimester bleeding. Right around 24 to 28 weeks, it's time to screen for gestational diabetes mellitus, and we use a two-step approach for this. Step 1 is a 50-gram oral glucose challenge, where you check their serum glucose 1 hour later. If that blood sugar comes back at 140 milligrams per deciliter or higher, it's a red flag, but not a diagnosis. You have to proceed to step 2, which is the fasting 100-gram, 3-hour oral glucose tolerance test, to actually confirm it. Vaccine safety is another area they love to test. Every single pregnancy requires a Tdap vaccine, ideally given between 27 and 36 weeks. You also need to make sure the patient gets the inactivated influenza vaccine, which is completely safe in any trimester. On the flip side, live vaccines like MMR, the live attenuated nasal flu spray, and varicella are strictly contraindicated. If you find out a patient isn't immune to rubella, you hold off and give them the MMR vaccine immediately postpartum. Entering the late third trimester, specifically between 36 and 38 weeks, you're going to do a routine rectovaginal culture for Group B streptococcus. If that swab comes back positive, the plan is to administer intrapartum prophylactic penicillin when they go into labor. However, if the patient has a history of GBS bacteriuria at any point during this current pregnancy, or if they had a previous infant who developed early onset GBS disease, you skip the swab and automatically give them intrapartum penicillin. Now, if a third trimester patient calls you complaining of decreased fetal movement, your immediate next best step is to order a non-stress test, or NST. You're looking for a reactive, reassuring result. That means a baseline fetal heart rate between 110 and 160 beats per minute, moderate variability, and at least 2 distinct accelerations within a 20-minute window. And remember, to count as an acceleration, it has to peak at least 15 beats per minute above the baseline and last for at least 15 seconds. But what happens if that NST is non-reactive and just isn't meeting those acceleration criteria? You immediately step up your surveillance to a biophysical profile, or BPP. The BPP takes the NST and adds an ultrasound to check amniotic fluid volume, fetal breathing, movement, and tone. A total score of 8 to 10 is great. It rules out fetal hypoxia. But a score of 4 or less, that indicates dangerous fetal hypoxia and means you need to deliver urgently. And honestly, finding oligohydramnios during the scan is a major red flag all on its own. Preeclampsia prevention is all about identifying your high-risk patients early on. If a patient has a history of prior preeclampsia, chronic hypertension, diabetes, or they're carrying multiples, you need a 24-hour urine collection for total protein at that very first prenatal visit, just to establish their baseline. Then, to actively prevent preeclampsia from developing, you start them on low-dose aspirin precisely at 12 weeks gestation. Finally, let's look at term membrane evaluation. If you suspect a patient's water has broken, you evaluate the vaginal fluid using a nitrazine test, which turns a distinct blue in the presence of alkaline amniotic fluid, or a Fern test, which shows a classic arborization pattern under the microscope. And here is the bottom line. If an intraamniotic infection, or chorioamnionitis, develops, the definitive next best step is immediate delivery, period. Gestational age doesn't matter anymore.